Hello guys, in this module we will be talking about small intestinal pathologies. So first we'll start with malabsorption and then we are going to end with small intestine obstruction. What is malabsorption? Malabsorption is when your gut does not absorb something properly. So it might be divided into three types. The first one, fat malabsorption, carbohydrate malabsorption, and protein malabsorption. We'll start with the easiest one, which is protein malabsorption. As you know, albumin is the most discussed protein. The albumin is lost due to malabsorption. What will be the symptom that you can see in your body? It will be edema. Next, coming to carbohydrates. What happens when carbohydrates are not absorbed? Carbohydrates are broken down into small molecules like simple carbohydrates, right? Basically, they are turned into simple sugar molecules. Now, when these carbohydrates are not absorbed, the sugar molecules will go directly into the intestine, will keep on attracting water with it, right? And this will result in watery diarrhea. So to check for carbohydrate malabsorption, they do a xylose test, D-xylose test. Fat malabsorption will lead to steatorrhea. Steatorrhea is fat in stools. Okay. What happens when you have steatorrhea? You see voluminous stools. Because of fat, the stool becomes voluminous. And the stools float. Why do they float? Because fat is not water soluble. And they can be pale if there is no bile in it. And in addition to that, the steatorrhea is very greasy and foul smelling. In addition to that, you have loss of fat soluble vitamins. What are fat soluble vitamins? I remember it as KEDA. KEDA means a worm in Hindi. Vitamin K, vitamin E, vitamin D, and vitamin A. How do you test for fat malabsorption? You do a fecal fat test. What is fecal fat test? Stool is collected over 3 days time and the amount of fat is measured in it. Normal should be less than 7 gram per day. So what is D-xylose? D-xylose is a simple monosaccharide. So to perform this test, the only requirement is an intact mucosa. No other enzymes are required for it. So what do you do in this test? Patient is given oral dose of D-xylose. Okay, and then subsequently you check the urine and venous blood because what happens is D-xylose is a monosaccharide which is absorbed in the proximal small intestine without any degradation by brush border enzymes or by pancreatic enzymes. No, nothing can degrade it because it is already in the simplest form, and subsequently it will be excreted in urine. Patient drinks the D-xylose solution. It goes in the gut and eventually the kidneys absorb it and then excrete it through urine. So the high serum levels and high urine levels are the normal. And what happens when your mucosa is altered? Small intestine mucosa is defective. That means the intestinal absorption will be decreased. It can't be absorbed into blood, nor can it be excreted in the urine. So what happens? All of it is excreted in the fecal matter, and this results in low serum levels and low urine levels. This is the abnormal. So you need to have a small intestinal mucosal disease, that is celiac disease. Celiac disease results in villus atrophy. So your small intestine have villi. Villi are finger-like projections. So when this happens, this can't absorb D-xylose, which will result in decreased urine and serum levels of D-xylose as we had just discussed. But if the malabsorption is due to enzyme deficiency, like pancreatitis, you have lipase deficiency, and in addition to that, other enzymes are also deficient. When this happens, you have normal absorption of xylose. So when the enzymes are deficient, you have normal absorption, but here mucosa is problematic and hence you can't absorb xylose, which was the only requirement. You need to have an intact mucosa. You don't need to have any enzyme, you just need to have an intact mucosa. That's how you can determine if there is carbohydrate malabsorption or not. But in some cases, you can have a false positive D-xylose test despite the normal mucosal absorption. And when can it be seen? When you have delayed gastric emptying. What does that mean? The stomach delays the emptying into intestine, which means there is slow absorption. So eventually when you check in the urine and serum levels, you find that there is no increase. These xylose levels are very low. You might think that it is carbohydrate malabsorption, but in fact you need to wait for a bit because it might be due to delayed gastric emptying also. Another thing where you can find a false positive D xylose test is impaired glomerular filtration. Your kidneys are bad and they do not filter, and hence your urine levels are low. The third place where you find a false positive D xylose test is SIBO, that is small intestinal bacterial overgrowth. You should know is that small intestine doesn't have any bacteria. All the bacteria are meant for large intestine. Small intestine is just meant for absorption part. The digestion and excretion part is left for large intestine. So all the gut bacteria mostly are present in the large intestine. Small intestine should not have any bacteria. This is when all the large intestine bacteria start entering the small intestine. And the bacteria ferment the D xylose. Before it can get absorbed, they start fermenting the D xylose. There is less amount to be absorbed by the gut, and this will lead to false positive D xylose. How do you treat small intestinal bacterial overgrowth? You just give them an antibiotic, that is rifaximin. You can give the patient rifaximin and then again test for D xylose test. If the D xylose test comes back positive even after giving rifaximin, then that means this patient did not have any small intestinal bacterial overgrowth. D xylose test did not change following treatment with rifaximin, then it is unlikely. We have just discussed in brief about the different type of malabsorption: carbohydrate, protein, and fat malabsorption. Now coming to the malabsorption syndromes. Before we proceed with the malabsorption syndrome, I just want to talk in brief about the diarrheas. Diarrheas can be steatorrhea, as we just discussed, fat and stool, watery, and inflammatory. Inflammatory meaning you can see RBC and WBC in the stool, right? It can happen with IBD and infections like Shigella. Watery diarrhea can be of two types, secretory and osmotic. To determine if it's secretory or osmotic, you can test for stool osmotic gap. Secretory diarrhea is when water and electrolytes are secreted into the stool to make it watery, right? It happens in cholera. Cholera, the toxin secretes fluid and electrolytes. What about osmotic diarrhea? You can take lactose intolerance as the best example for osmotic diarrhea. The lactose is a high concentration solute and it draws in water, and this will lead to watery diarrhea. We were talking about stool osmotic gap. You do not have to remember this equation 290 minus 2 sodium plus 2 potassium. It's not that important. You just need to remember if osmotic gap is more than 50, it is osmotic diarrhea. If it is less than 50, it's secretory diarrhea. Osmoles basically draw more water. When the water is more, the sodium and potassium concentration will decrease. And this will lead to increased osmotic gap because all of this concentration is getting decreased. That means the number here will come out lower and lower. That means the answer will keep on increasing. Whereas in secretory diarrhea, toxins secrete water and electrolytes. Both of them are secreted. This will decrease. Electrolytes keep increasing here. So the number becomes higher here. That means the total becomes lower. Osmotic gap is decreased. Lactose intolerance. When a person eats lactose containing meals and he has diarrhea following this, that means he has lactose intolerance. So lactose intolerance, we said that it comes under watery diarrhea osmotic type. And the stool osmotic gap increases. Stool pH decreases because lactic acid is acidic, and the lactose hydrogen bread test comes back positive. What happens here is lactose, which is unabsorbed, is fermented by gut bacteria. Why this happens? Lactose, with the help of lactase enzyme, is broken down into simple carbohydrate. But when it is unabsorbed, the lactose is unabsorbed in the gut, the bacteria ferment this lactose and ferment it and convert it into hydrogen and methane. That's why the hydrogen breath test comes back positive. What about chronic pancreatitis? Chronic pancreatitis leads to deficiency in lipase enzyme. Now, this lipase enzyme deficiency leads to fat malabsorption, and this leads to greasy, foul smelling, all the steatorrhea part. In addition to that, pancreatitis will have abdominal pain radiating to the back. What about celiac disease? Celiac disease may you have small intestine villus atrophy. Now, iron is absorbed in the small intestine. That will lead to iron deficiency anemia, which will cause microcytic anemia. Villus atrophy, iron deficiency, microcytic anemia. And you have increased stool osmotic gas. Next, SIBO, we just discussed ki it will cause bacterial overgrowth, fermentation can occur. In addition to that, small intestine is also responsible for B12 absorption in the ileum. Iron is absorbed in the duodenum, whereas B12 is absorbed in the ileum part. So, small intestinal bacterial overgrowth, the bacteria will grow and start feeding on the B12. And this will lead to B12 deficiency, which will cause macrocytic anemia. We have just completed the discussion about malabsorption. Now we will proceed with the IBS, that is inflammatory bowel syndrome. What is IBS? IBS is a functional bowel disorder. That means there is no problem in the small intestine or in the large intestine. The intestine is perfectly normal in structure. But the function is the problem over here. The structure is normal, but the function is impaired. That will lead to either diarrhea predominant type or constipation predominant type or both. Let's see. How do you evaluate a suspected IBS? First things first, IBS, why does it occur? Due to visceral hypersensitivity and abnormal GI motility. It might occur due to cholecystokinin, CCK, cholecystokinin. What other things can you notice? It can occur in young female whose age might be less than 45 years. This is exacerbated by pregnancy. You have to know that pregnancy is like the most vulnerable stage of the female where her immune system is totally thrashed, and she at the end of the trimesters she becomes so vulnerable that her body starts to show all the dormant autoimmune conditions, or if there were any underlying dormant conditions that were present in the female, they start to show up. So pregnancy can exacerbate the IBS. Any comorbid conditions like anxiety, fibromyalgia, depression, and stress. Did you know that your gut has enteric nervous system? So what happens in IBS is this enteric nervous system gets overactivated, which will cause your constipation or diarrhea. So anything that is overactivating your enteric nervous system like anxiety, stress, depression, fibromyalgia, these conditions can contribute to the IBS part of a female. Coming back to the evaluation part. Evaluation may you need to check if the patient has any abdominal pain for more than 1 day per week, and it should be for more than or equal to 3 months. Okay, patient is having abdominal pain for more than 1 day a week, and this should be going on for more than 3 months, more than or equal to 3 months, and any of the two of should be present. The abdominal pain should be linked to defecation. That means pain should either improve with defecation or worsen with defecation. Second thing you can see is change in stool frequency. That means the number of times a person visits the bathroom. Another thing you can see is change in stool form. That means consistency of the stool. It might become too liquidy or it might become too hard. And the patient should not have any alarm symptoms. What does alarm symptoms mean? Alarm symptoms mean the patient is old, that is more than 50, I think. Patient has iron deficiency anemia, any weight loss, melena. We can see age more than 50, rectal bleeding and melena, iron deficiency anemia. And there should not be any fasting diarrhea, that is nocturnal. Nocturnal diarrhea means it might point to IBD or secretory diarrhea. Worsening abdominal pain. They should not have any family history of IBD or colorectal cancer. Any inflammatory markers like CRP or fecal calprotectin. Fecal calprotectin is an inflammatory marker. So if you have any alarm symptoms, then you need to go for a colonoscopy or flexible sigmoidoscopy. Colonoscopy is better. So first look at the symptoms. If you have any of these, you should check if it is constipation predominant or if it is diarrhea predominant. So there are a series of tests which we do for IBS with constipation and IBS with diarrhea. For constipation predominant, you need to do CBC and radiography. If these come back normal, then treat for IBS constipation type. What if these come back abnormal? You see something, you find something on the imaging. What do? You go for colonoscopy. For IBS with constipation, you do radiography and flexible sigmoidoscopy and colonoscopy if the results come back abnormal in the radiography part. What about diarrhea predominant type? You need to do CBC because we need to check if there is any anemia, iron deficiency anemia. You need to do stool culture for infection. You need to check for celiac disease. You need to do CRP or fecal calprotectin to check for IBD, right? CRP and fecal calprotectin are inflammatory markers. Then you need to go for 24-hour stool collection. If this comes back normal, treat for IBS. If comes back abnormal, then you need to treat the underlying cause and additional evaluation, that is colonoscopy or flexible sigmoidoscopy, and if possible, biopsy should be done. So I have written a small note over here. Fecal calprotectin. What is it? It is a protein found in the neutrophils. It is positive if the patient has IBD. Fecal DNA testing. Screening for colorectal cancer, especially in patient at average risk for colon cancer. Example, patient age is more than 45. So we can just see the evaluation of IBS with diarrhea is stool culture, celiac screening, 24-hour stool collection and flexible sigmoidoscopy or colonoscopy and biopsy. Now coming to the IBS versus IBD differentiation. There is no blood in stool. So fecal occult blood testing comes back negative in IBS, whereas it is positive in IBD. Inflammatory markers are not present in IBS, whereas it is present in IBD. Nighttime awakening due to pain and diarrhea does not happen in IBS. It does happen in IBS. Even if the patient has decreased sleep, that will lead to increased number of symptoms during the day, not during the night when he's sleeping. Now coming to the management. So how do you manage IBS? It is according to the symptoms only. For abdominal pain, you give an antispasmodic. This is the first line. So what is the antispasmodic you give? Hyoscyamine. Second line is TCAs, tricyclic antidepressants like amitriptyline. This is important, they ask. For diarrhea, what do you give? First line is soluble fiber, psyllium. In India, we have isabgol, psyllium husk. And then loperamide, it decreases the motility. Next is second line are bile acid sequestrants, that is cholestyramine, and serotonin 3 receptor antagonists like alocetrol. And you can follow a FODMAP diet. Important question. For what is FODMAP diet? Fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Basically, it is asking you to decrease all kind of carbohydrate intake. Low FODMAP diet. Fermentable monosaccharides, disaccharides, oligosaccharides, all should be decreased, and polyols should also be decreased. What about constipation? Constipation, में first you need to give psyllium husk, that is soluble fiber, and you need to start on laxatives like PEG, polyethylene glycol. Second line is lubiprostone and linaclotide, tenapanor. The second line constipation drugs are not so important. You need to remember the first line. First lines are more important, obviously. We completed our discussion with IBS. Now let's move forward to IBD. What is IBD? IBD is inflammatory bowel disease. IBS is irritable. This I stands for irritable, not inflammatory. IBD is inflammatory bowel disease. Inflammatory bowel disease is an autoimmune disorder. It is divided into two types. First one is Crohn's and second one is ulcerative colitis. This is a very confusing topic for most people, but I made a mnemonic so that I can remember majority of the portions of Crohn's and ulcerative colitis. For me, it's all about the disease should fit in its name. It should not confuse people. So that's how I relate with the disease. I made a mnemonic for Crohn's disease. It is Crohn asks for stones. What does Crohn mean? So I relate to Crohn as corn. Corn. So you have foot corn, feels like stone, right? The foot corn, the corn which you have on your foot feels like a stone. And what does this stone remind me of? It reminds me of cobblestone. I know this is a bit lame, but I just try to remember it like that. Or you don't have to remember this. Stones is more than enough for that. Okay. What does ask mean? Ask means aska. What is ASCA? It is positive for anti-Saccharomyces cerevisiae antibodies. So ask is ASCA. Now what does stone mean? Stone mean cobblestone appearance. Another stone means kidney stone appearance. And third is gallstones. This is the mnemonic that I have made for corn disease. Now coming to ulcerative colitis. For me, the name should summarize the disease. So I have made it. I have summarized everything that happens in ulcerative colitis in its name. What does ulcerative mean? Ulcerative mean ulcers. And where do these ulcers occur? It occurs in colon. So ulcers in colon. And what is the definition of ulcer? Ulcer is a discontinuity in the mucosa and submucosa. So where does this inflammation occur? It occurs in the mucosa and submucosa only. As I said, the name should summarize the disease. So ulcerative means ulcers. Where are the ulcers? In colon. And what is an ulcer? Discontinuity in mucosa and submucosa. And that is where our inflammation is happening. It occurs in colon and never involves small intestine. And I remember it for continuous colonic lesion. Whereas in Crohn's, you have skip lesions. And Crohn's can occur any portion of GIT. From mouth to anus, it can occur anywhere. So you can have oral ulcers and you can have rectal ulcers. You can have any kind of ulcers. Another thing, colitis and cholangitis. Both of them sound very similar. So ulcerative colitis is associated with cholangitis, primary sclerosing cholangitis. And this is ANCA positives, P ANCA, MPO ANCA, whatever it is. ANCA, MPO ANCA or P ANCA positives. So complications. I have made a story for the complications. So I remember it like this. Initially, you have a small ulcer. This will progress into a full-blown abscess, which will cause toxic megacolon. Your colon has become so huge that it might perforate, right? In abscess, you see bloody diarrhea. In toxic megacolon, you have loss of hostra. Hostra are basically the pouches of colon. So all these pouches are lost. You have a straight lead pipe-like appearance of colon. Loss of hostra, lead pipe appearance. The pouches of colon are lost and this will lead to lead pipe appearance. Now let's have a look at the topic. Ulcerative colitis. Colitis means colon inflammation and it is a continuous colonic lesion. And it always has rectal involvement. That means left lower quadrant pain is always present. We just said that ulcer is mucosal and submucosal inflammation. We have ulcerations, loss of hostra or lead pipe appearance. This can be seen in toxic megacolon as we just mentioned. And then we said that microscopy pe you can see crypt, abscess or ulcers. We just discussed ulcer might develop into abscess. Bleeding can be seen. There are no granuloma formations. You have to remember this. Granulomas are not seen in ulcerative colitis, but Crohn's does have granuloma. Next, coming to complications, we said that there is colon inflammation, fulminant colitis, toxic megacolon. We just discussed toxic megacolon, and it might lead to perforation. You need to remember toxic megacolon. It is a very important complication of ulcerative colitis, and we will discuss in detail about toxic megacolon in large intestinal pathologies. What is the intestinal manifestation of ulcerative colitis? You see a bloody diarrhea. Next, coming to extraintestinal manifestation. One thing you have to know that inflammatory bowel disease is an autoimmune disorder. And for some reason, autoimmune disorder love to attack eyes and joints. Okay, so you have eye inflammation, episcleritis, uveitis, and joint inflammation, that is arthritis, peripheral and spondylitis. And in addition to that, you can also see some kind of rashes also, like erythema nodosum. And another thing is pyoderma gangrenosum. Ulcerations are mostly present in Crohn disease. Mouth to anus, you can have anywhere ulcer. Okay, aphthous stomatitis. Next is a specific manifestation of ulcerative colitis, that is cholangitis. I just said that colitis and cholangitis sound very similar. That's why I have placed it here. And treatment includes 5 ASA, that is amino salicylic acid preparations. Mesalamine. This is very important. It is well tolerated, including in patients with sulfa allergies. This can be given even in pregnant patients. In addition to that, you can use 6-mercaptopurine and infliximab. Infliximab is TNF alpha inhibitor. Or you can do a colectomy. Why colectomy? Because it is usually involving colon. If you just remove the colon, you won't have any colon related symptoms in the future, right? Next, coming to Crohn's disease. Crohn's disease, we said ki Crohn as for stones can occur in any portion of GIT, mouth to anus. I think of it as corn. So you eat corn from mouth, right? Mouth to anus, it can occur anywhere. Mostly it involves the ileum and colon. This will cause right lower quadrant pain. You have skip lesions and rectal sparing can be seen, whereas here rectal involvement is always present. What about inflammation? It is transmural inflammation. What does transmural inflammation mean? Transmural inflammation means that it involves all layers, whereas ulcerative was involving only the mucosa and submucosa. What happens when all layers are involved? It leads to fibrosis. Fibrosis will cause strictures, and you can also see fistulas because all of the layers are involved in the inflammation. We just discussed cobblestone mucosa is seen, and another thing you need to remember is creeping fat is also seen. Bowel thickening, bowel wall thickening, because you have fibrosis, you see a bowel wall thickening. String sign on small bowel follow through. Linear ulcers are seen, and fissures can also be seen. Microscopy में you see granulomas and lymphoid aggregates. You have to remember Crohn में you see granulomas. This is an important point. Complications: malabsorption or malnutrition, colorectal cancer, increased risk with pancolitis. Another complication that you can see is fistula. So what fistulas? Enterovesical from colon to bladder, enterocutaneous from bowel to skin. And then you can see strictures, as we just said, key fibrosis will cause strictures. And these strictures will cause obstruction. Oh my god, we have to emphasize the amount of questions they ask on this. Basically, they give you a scenario of patient who has had recurrent diarrhea episodes in the past, and now he has abdominal pain, bilious vomitings and everything, and they present the patient as an obstruction case and then ask what was the predisposing condition that lead to this. So it is Crohn's disease, guys. Crohn's disease caused him strictures, and now these strictures are causing obstruction in this patient. And another complication is perianal disease. Intestinal manifestation is diarrhea, which may or may not be bloody. Extraintestinal manifestation, as I just said, autoimmune disorder loves to attack eye and joints. So arthritis is there and eye inflammations are there. In addition to that, ulceration, I said ki Crohn may you see ulcers anywhere. This is more of a Crohn specific manifestation than ulcerative colitis, and you have rashes also. Now coming to kidney stone. Why do you see kidney stones in Crohn disease? Stone, fat malabsorption. Fat is carried by bile acids. Fat is absorbed in the body with the help of bile acids. When you have fat malabsorption, fat is not absorbed. This will lead to cause gallstones. One is this part. Second thing, the fat which is not getting absorbed binds with calcium and this gets excreted. Originally, this calcium was supposed to bind with oxalate. So what happens? Calcium is going out of the picture, oxalate levels increases. So this will lead to kidney stones. Another thing we discussed was ASK. So ASCA is positive. Coming to the treatment, you need to give all the immunosuppressive drugs. Glucocorticoids are given, azathiopurine. This is also immune suppression drug. Antibiotics. What are the antibiotics you need to give? Ciprofloxacin and metronidazole. And then biologics like TNF alpha inhibitors, infliximab, infliximab and adalimumab. Both of them are TNF alpha inhibitors. Now coming to disease activity, fecal calprotectin is used to monitor activity and distinguish from non-inflammatory disease because it is an inflammatory marker. Now other things that we should note is smoking is a protective factor in ulcerative colitis, but then it causes flare-ups in Crohn's. Some points you need to remember: after bowel resection, there is loss of absorptive surface area. This will decrease the intestinal transit time. When the intestinal transit time decreases, this causes postprandial voluminous diarrhea and weight loss due to malabsorption of macro and micronutrients. One more thing, we said कि Crohn's disease में you have stones, both kidney stones and gallstones. Ulcerative colitis means you should not have any kidney stones. But the question says that patient with ulcerative colitis develops kidney stones. And analysis means it is uric acid stone. What led to the development of the stones? Answer is chronic diarrhea is causing bicarbonate and water loss. This will cause hyperconcentrated urine, which will lead to uric acid stone. So they may twist this around and ask you what kind of stone develops in ulcerative colitis. So you need to remember uric acid stones are might be seen in ulcerative colitis. As I had just mentioned that examiners love to question about the stricture and small bowel obstruction related to Crohn's disease. There was a question like this: 25-year male, complain of abdominal pain, nausea, vomiting since 2 months. Initially intermittent pain and in right lower quadrant. We said ki right side is Crohn's, left side is ulcerative colitis because left side rectum is always involved. And this right left quadrant pain progressed. It became diffuse severe. The patient had bilious vomiting and has no bowel movements in 2 days. Occasionally passes flatulence. Occasionally passes flatus. What does that mean? We have a partial SBO. How do we know that? Because he is passing gas and bilious vomiting. Where is bile secreted? In the small intestine. When you have a small intestine obstruction, you will have bilious vomitings. Patient is a known case of Crohn's with ileal involvement and is on infliximab, that is TNF alpha inhibitor. He is a smoker. What did we say? Smokers are a bad combination for Crohn's disease because smoking flares Crohn and vitals are stable. Since vitals are stable, we can, wait for this patient. We do not have to take him to emergency surgery. Abdomen is distended, tympanic, and tender to palpation. Signs towards small bowel obstruction. There is no rebound or guarding. That means it is not an emergent condition. We can wait because this is partial SBO right now. Diagnosis. What is the diagnosis? Partial SBO. It might be due to stricture. Stricture, bilious vomiting, severe abdominal pain, partial or complete obstruction. If it is partial obstruction, gas will be there. If it is complete, gas is not there. On examination, distended tympanic abdomen, high pitched, that is tympanic bowel sounds are there. So this is all, mostly this is all SBO, but then stricture is causing the SBO. That's why the same symptoms apply here. There is another comparison, SBO versus ileus. So what is ileus? Small bowel motility is obstructed in ileus, and this happens due to some insult to the intestine. It is due to exposure to insult that stunts bowel. What is that insult? Recent intra-abdominal surgery or high dose opioids might cause ileus. Toxic megacolon, we just discussed that lead pipe rigidity is there, hemodynamic instability might happen, watery diarrhea. C. diff is one of the most important cause of toxic megacolon. Here, there's a question that has basically described that patient has IBD disease and a perianal fissure, complication of Crohn's, we can say, and WBC counts are elevated, inflammatory markers are there, and intestinal obstruction is also there. They are pointing towards toxic megacolon and asking what is the next best step. Colonoscopy, endoscopy are not the important option. Ultrasound is also not done. So we have our choice between these two, metronidazole or MRI abdomen. And we point towards C. diff that is treated with metronidazole IV. Just a few more important points that you need to know. Inflammatory markers are increased in IBD, obviously, because this is an inflammatory condition. Fecal calprotectin, inflammatory marker. Anemia of chronic disease is present. You need to remember that. Few important points regarding the treatment of ulcerative colitis and Crohn's disease. What is mild ulcerative colitis and what is moderate ulcerative colitis? If the patient has less than 4 bowel movements, then that is mild ulcerative colitis, and you need to give them a 5-ASA, that is mesalamine. Whereas if the patient has more than 6 bowel movements, then that is moderate ulcerative colitis, and you need to give them TNF alpha inhibitors like infliximab. And If the ulcerative colitis is confined to rectosigmoid, you can give them suppositories or enema of mesalamine. But if the disease is more extensive, then oral mesalamine should be given. You might remember HLA-B27 has a mnemonic called PAIR: psoriasis, ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis. So in some cases, these diseases might coexist. For example, ankylosing spondylitis and IBD. So to relieve the pain in ankylosing spondylitis, if a doctor is giving NSAIDs, right, this can exacerbate IBD symptoms because there is a disruption in COX-mediated immunomodulation or intestinal microcirculatory blood flow. This will lead to exacerbation of IBD symptoms. So you need to be careful if the patient has both IBD and ankylosing spondylitis when giving NSAIDs to such patients. Smoking, we just discussed that it is a protective factor in ulcerative colitis, whereas in Crohn's it flares up the disease. Smoking and young age at diagnosis is the significant risk factor for uncontrolled inflammation and disease progression despite medical therapy. If a patient is young in age and he is smoking, you need to be really careful because this might lead to future disease progression and continuous flare-ups despite medical therapy. So what disease progression are we looking at? Strictures, obstruction, and fistulae. We know all of them. If the patient has moderate to severe Crohn's disease and you need like immediate improvement, then you can give them glucocorticoids because glucocorticoids provide immediate improvement for moderate to severe Crohn's, and biologic agents like infliximab, adalimumab, they take weeks to show an effect. And as I had just mentioned, that pregnancy is like a vulnerable period for females. All kind of dormant conditions or existing conditions flare up. Pregnancy is a high risk period for patients with ulcerative colitis due in part to placental cytokines that worsen colonic inflammation. What this sentence is trying to say is placental cytokines worsen the colonic inflammation in pregnancy. What are the maternal complications and what are the fetal risks we are looking at? The maternal complications include worsening of ulcerative colitis disease activity, and this can lead to hematochezia, blood in stool, anemia, and in rare cases, toxic megacolon. What about the fetal risk? Fetal risk includes preterm delivery and small for gestational age baby. And in addition to this, fertility rates are also lower in patients with active ulcerative colitis. Most medications that are used in the management of ulcerative colitis are considered safe throughout the pregnancy and can also be used during the breastfeeding except sulfasalazine. We completed our discussion with inflammatory bowel disease. Now let's go towards celiac disease, one of the most important diseases of small intestine. These are like the most important diseases of the small intestine that you have to be thorough with. Celiac disease. Celiac disease has many names. It is called gluten sensitive enteropathy. It is due because this is due to antigens from gluten. Celiac's proof. You need to remember IBD and celiac. These are the most important diseases of small intestine, and both of them are autoimmune diseases. There's a mnemonic to remember the association of these genes. I ate too much dairy. I ate. 8 means number 8. 2 is number 2. And dairy is DQ. So HLA, DQ, dairy. Dairy is DQ 2 and DQ 8. So HLA, DQ2 and DQ8 are the important genes that you need to remember. And Northern European descent. Where does this occur? Celiac disease occurs in small intestine, and you need to remember that this occurs in small intestine. What are the parts of small intestine? I remember it as DJ ileum. I know it is funny, but I remember it DJ ileum. That is duodenum, jejunum, and ileum. So where does the celiac disease affect? You need to remember this. It occurs in the distal duodenum and proximal jejunum, and this will cause malabsorption because small intestine is meant to absorb most of the vitamins and minerals, carbohydrates, everything it is supposed to absorb, but because it is affecting the small intestine, we have malabsorption and steatorrhea. Both carbohydrate and fat malabsorption can be seen here. What is the management? You need to make a gluten-free diet. During the initial part of our video, we said that there is villus atrophy that is seen in celiac disease. What are villi? They are finger-like projections seen in small intestine. This is the normal healthy villus. You can see there are finger-like projection in the small intestinal cell. Here you see villus atrophy. The villi are getting atrophied and there is lymphocytes, intraepithelial lymphocytes and crypt hyperplasia. Let's look at what exactly is happening in celiac disease. You know gluten. What is gluten? Gluten is a protein that is found in wheat, barley, rye and oats. The gluten releases gliadin. This gliadin passes inside the cells and we have tissue transglutaminase. This removes amine group from gliadin. It becomes deamidated gliadin. Now this deamidated gliadin is given by antigen presenting cells. These are the antigen presenting cells which present it to the T cell. We have a hypersensitivity reaction that starts here. Now these T cells release interferon gamma and interleukin 21 which act and also activate B cells. Now B cells start releasing antibodies. What are the antibodies that the B cell release? It is anti-TTG, that is tissue transglutaminase antibody, anti-deamidated gliadin, and anti-endomysial. So these two things, tissue transglutaminase and deamidated gliadin. Antibodies are released against both of these substances. And another thing is anti-endomysial antibodies. So you can see all these three antibodies here. Now manifestations we'll discuss in a few minutes. B xylose test is abnormal. We said key for xylose test to be normal, your villi mucosa should be healthy. But here villus atrophy is there, mucosa is not healthy, so it cannot absorb D xylose test. That's why it comes out abnormal. Carbohydrate malabsorption can be seen. Serology mein we just said ki IgA antibodies against anti-tissue transglutaminase is seen, anti-endomysial is seen, and deamidated gliadin antibody is seen. Histology, you have loss of villi, mucosal atrophy, crypt hyperplasia, and intraepithelial lymphocytes. If you look at this entire diagram, you have your celiac disease. One more thing that you have to notice, there is increased risk of malignancy, that is T cell lymphoma. So to check for celiac disease, you check the tissue transglutaminase antibody, IgA, TTG, and IgA antibodies. Both of them you need to check because some patients have IgA deficiency. These antibodies can come back as negative. So what do you do in these cases? So let's view this. If the antibody for tissue transglutaminase comes back as positive, then there is no doubt that this is celiac disease. We just have to do duodenal biopsy and check for all these villus atrophy, crypt hyperplasia, intraepithelial lymphocytes, and mucosal atrophy and declare that it is a celiac disease. But if duodenal biopsy comes back negative, then that means there is no disease. Even if the antibody comes back as positive, you have to do duodenal biopsy. It is mandatory to confirm celiac disease. What happens if the tissue transglutaminase antibody comes back as negative? You need to check IgA antibodies. If the IgA antibodies are normal, then that means it is actually negative. It is not celiac disease. What if the antibodies come back negative and IgA is also decreased? If IgA is decreased, then you should check for IgG antibody. If IgG comes back positive, then you need to go with duodenal biopsy to confirm the disease. Right? So first check for IgA antibody. If it is not there, check if actually the patient has IgA antibody. If patient has IgA, then that means the test is actually negative. But if he doesn't have IgA, then you should check IgG. I know I might have confused everyone. Okay, celiac disease is the proximal small bowel disease, and you need to do endoscopy for this. Whereas IBD is a large bowel disease, and you need to do colonoscopy for it. So there's a patient with celiac disease scenario. What happens to the calcium, phosphate, and parathyroid hormone? Celiac disease causes fat malabsorption. That means your fat soluble vitamins are lost. That is KEDA. Vitamin K, E, D, and A. Vitamin D deficiency leads to what? Parathormone increase and calcium and phosphorus decrease. Let's talk about the clinical manifestations of celiac disease. These manifestations are due to autoantibodies. No, we just discussed that the other names for celiac disease is gluten sensitive enteropathy and celiac too. What are the risk factors for celiac disease? Patient should have a first degree family relative with celiac disease or Down syndrome, or if patient is autoimmune condition like type 1 diabetes, autoimmune thyroiditis. If patient has any other autoimmune condition, that means he is at risk for celiac disease. GI manifestation, we already know that we have diarrhea. Steatorrhea may be there because of fat malabsorption, and all this malabsorption will cause weight loss. In addition to that, abdominal pain, flatulence, and bloating, all the GI symptoms will be there. What about late manifestation? Ulcerative jejunitis might be there. Enteropathy associated T cell lymphoma. You need to remember that celiac disease causes increased risk for T cell lymphoma. This is very, very, very important. Dermatitis herpetiformis. Celiac disease is associated with a skin condition called dermatitis herpetiformis. What is dermatitis herpetiformis? Patient has grouped pruritic papules or vesicles on the extensor surface, like elbows or knees. Why it is called herpetiformis? Because they look like herpes infection. In herpes infection also you see papules or vesicles which are fluid filled and they are grouped together. And because there is pruritus, right, in these papules or vesicles, you can see erosions and excoriations too. And you can see atrophic glossitis. Why atrophic glossitis? Because you're losing so many vitamins and minerals. This will cause glossitis, smooth red tongue with burning pain. Next, vitamin D deficiency, we said KEDA. Our KEDA is lost. What do you mean by KEDA? Fat soluble vitamins. Secondary hyperparathyroidism can be seen. Next, bone disorders like osteomalacia or osteoporosis in adults and rickets in children. This is due to vitamin D deficiency. Then you have iron deficiency anemia. Why? Because small intestine duodenum was supposed to absorb iron, and since our celiac disease has disrupted the mucosa, there is no iron absorption, and this is causing iron deficiency anemia. Neuropsychiatric, you have peripheral neuropathy, depression, and anxiety. You need to remember you have stocking glove syndrome. That means in the palms, stockings and glove. Like glove means where do you wear your gloves? On your palms, right? So in the palms, there is loss of sensation or decreased sensation. They might ask questions like there is a patient who has been having burning sensation in his hands and feet for past several months. There is also soreness in his mouth. Intermittent episodes of diarrhea, bloating sensation were also there in this patient. His tongue was red and smooth. Neurologic examination shows decreased pinprick and vibration sensation in the bilateral fingers and toes. Muscle strength and deep tendon reflexes are normal. Lab may show microcytic anemia. What is the cause of this patient symptoms? All of this is pointing towards celiac disease, and the cause of the symptoms is the peripheral neuropathy due to the autoimmune process. In addition to that, patient may also have depression or anxiety. There's a question over here. 14-year male complain of rash lasting 3 weeks, red spot on his arms and legs that itched and burned. These are these have since filled with clear fluid and have crusted over, less energy, lost 3.6 kg, conjunctival pallor is present, erythematous vesicular symmetrically distributed rash over extensor surface of elbows and knees. So what's the difference between dermatitis herpetiformis and herpes infection is herpes has dermatomal distribution, whereas dermatitis herpetiformis is present on the extensor surfaces. Another important thing you have to remember that in children, the main presenting sign of celiac disease may be growth delay. weight loss, and poor linear velocity. So it can occur in the absence of diarrhea. So you should look out for this also. If the patient has growth delay in the absence of diarrhea, it might be celiac disease. Because in some patients, extraintestinal symptoms may be the sole presentation. There may be no GI features, only extraintestinal symptoms are the main presenting feature. Pediatric findings may include failure to thrive for weight loss, short stature, that is, linear velocity of growth is decreased, and sometimes delayed puberty and amenorrhea may also be seen. For example, they had a question like there's a 13-year male who has poor weight gain. He is the shortest student in the class. Weight is 5th percentile and height is 10th percentile. He has occasional abdominal discomfort and bloating. His appetite is good and balanced. Known case of type 1 diabetes since 3 years. Insulin dose decreased recently due to recurrent hypoglycemia episode. As we had mentioned that risk factors include autoimmune conditions like type 1 diabetes, then there's an increased risk of celiac disease in those patients. So patient had type 1 diabetes since 3 years and due to malabsorption, he is having recurrent hypoglycemia episodes. Labs show iron deficiency anemia and thrombocytosis. This is a sign of celiac disease. Coming to the management. Management is really simple here. The only thing you need to manage is the gluten-free diet. Gluten-free diet is the main management of this disease. Other than that, you might have nutritional deficiencies. You need to tend to those deficiencies. Most common deficiencies are iron, calcium, vitamin D, folic acid, and rarely thiamine. So you need to supplement the patient with these medications. You need to prevent bone loss. Obtain a DEXA scan at the diagnosis and repeat DEXA after 1 year if the patient has osteopenia. If the patient doesn't have osteopenia, you do not have to repeat the DEXA scan. But if there was osteopenia present at the time of diagnosis, then you need to repeat a DEXA scan. Vaccinate the patient, pneumococcal vaccinations. If the patient has dermatitis herpetiformis, dapsone is the treatment in addition to gluten-free diet. Why do you need to vaccinate the patient with pneumococcal vaccination? There is associated hyposplenism. When you have a small spleen, you are susceptible to more bacterial infections. Yep, if you see broadly, the only management of celiac disease is gluten-free diet, and for dermatitis herpetiformis, it is dapsone. These are the two main things that you need to remember. That's all with celiac disease. Now coming to SIBO, that is small intestinal bacterial overgrowth. We had already discussed in the start that the gut bacteria are mostly present in the large intestine. Small intestine is only meant for absorption. So normally bacterial growth in the small intestine is inhibited by gastric acid and pancreatobiliary juices, intestinal peristalsis, and immunoglobulins in the intestinal secretion. So in intestine you have IgA antibodies. All of these contribute to the inhibition of bacterial growth in the small intestine. The ileocecal valve. Ileocecal valve is the part where your small intestine and large intestine are separated. So this is your ileocecal valve. So ileocecal valve, small intestine and large intestine. Ileocecal valve is the physical barrier preventing colonic bacteria. And hence, SIBO can occur when you have removed this valve, that is, ileocecal resection is done, or when there is motility disorder. What are the risk factors of SIBO? Anatomic abnormalities like strictures are there. Surgery is done, like ileal resection or gastric bypass surgery. Small bowel diverticulosis is there. Motility disorders like diabetes mellitus, scleroderma, opioid use, all of these decrease the enteric nervous system stimulation and hence motility disorder occurs. Immunodeficiency, that is IgA deficiency, chronic pancreatitis, gastric hypochlorhydria, and proton pump inhibitor use. Whatever we had discussed here, right? Gastric acid was preventing the bacterial growth. So if there is gastric hypochlorhydria, proton pump inhibitor use, then you might see SIBO. Pancreatitis, pancreatobiliary secretion or juices were preventing the growth, and then immunodeficiency of IgA deficiency. Immunoglobulins were preventing the growth. Motility disorder, intestinal peristalsis was preventing the growth. Anatomic abnormalities, yeah, physical barrier. All of these things were preventing the intestinal, small intestinal growth of bacteria. Now, when all of these, now, if there is problem in any of these, this might cause SIBO, that is small intestinal bacterial overgrowth. What are the symptoms of SIBO? Bloating, flatulence, chronic watery diarrhea, possible malabsorption, B12 is decreased, folate is increased, carbohydrate breath testing should be done in this case, endoscopy with vaginal aspirate or culture. Treatment is antibiotics should be given. Because it is bacterial overgrowth, you need to give antibiotics. Most important one is rifaximin. You can start with rifaximin. Ileum is supposed to absorb B12, but the bacteria over here are eating all of this B12. That's why you have B12 deficiency, and this will lead to macrocytosis, microcytic anemia. Small intestine is supposed to absorb all the carbohydrates, and hence you see carbohydrate malabsorption. You can see breath testing can be done for lactulose. Endoscopy should be done. Oral antibiotics are the treatment. And important thing, do not consider SIBO in patients with regular bowel movement. If the patient has normal bowel movement and you're imagining that this is SIBO, then you are in a wrong direction. That is it for SIBO. Now progressing to the next topic, that is appendicitis and pseudoappendicitis. This is one of the most easiest topics, probably because I have undergone appendectomy. Let's go. What is appendicitis? This is your small intestine, this is your large intestine. Ileum is the terminal part of small intestine. It connects into cecum. Now, cecum has a vestigial organ, appendix, the presence of which is of no use. That is why it's called vestigial organ. Sometimes this appendix gets inflamed. And what are the conditions that cause inflammation of appendix? In adults, it's usually fecolith. What is fecolith? Feces forms a stone that is called fecolith. And in cancer also, you can see appendicitis. What about children? In children, there's lymphoid follicular hyperplasia, which causes lumen obstruction. When the lumen gets obstruction, there is increased intraluminal pressure, which causes blood vessel occlusion. Obviously, this leads to ischemia. Ischemia will obviously cause pain, visceral pain. And how does this visceral pain occur? Ischemia causes activation of visceral efferent nervous system at T8 to T10, which causes visceral pain and diffuse periumbilical pain. So initially, due to the activation of afferent nervous system, you have periumbilical pain initially. Now, as the inflammation extends to serosa, it irritates parietal peritoneum. Initially, it was only visceral peritoneum. That's why you had periumbilical pain. Now parietal peritoneum is also getting involved. Then you will have somatic pain. This is how it progresses in children. Now coming to the symptoms, you have a score called Mantriel score. Mantriel score is also called as modified Alvarado score. So you need to have migration of pain. A is anorexia, N is nausea or vomiting, T is tenderness, R is rebound, E is elevated temperature, L is leukocytosis, S is shift of WBC to the left. Only the tenderness in right lower quadrant and leukocytosis score 2 points, otherwise it's just 1 point each. And if the score is more than 4, then that means there is suspected appendicitis. Before we progress to the diagnostic imaging part, we need to learn about a few signs in appendicitis. First, you need to know about the McBurney's point. What is McBurney's point? You have your anterior superior iliac spine over here and umbilicus over here. So the 1/3 distance between this umbilicus and anterior superior iliac spine, this is the region which is called McBurney's point. Now let's check the signs of appendicitis. First is peritoneal signs. You have to remember these peritoneal signs. What are peritoneal signs? When the inflammation causes peritoneal irritation. What are the peritoneal signs? There is rebound tenderness. What does this mean? Rebound tenderness is you are palpating the patient's abdomen. When you palpate the abdomen, you don't have any pain. But when you remove your hand, the patient has increased pain. Then that is called rebound tenderness. What is involuntary guarding? When the patient tenses the abdominal wall muscles when you are palpating. It is called involuntary guarding. What is rigidity? When the abdominal wall muscles are in persistent tension, it is called abdominal rigidity. These are the peritoneal signs you have to remember. Next comes psoas sign. What is psoas sign? When you have right lower quadrant pain with extension of right thigh. That means you have flexed your right thigh, and when you are trying to extend the thigh, you have pain in the right lower quadrant. That means it is psoas sign. What is obturator sign? I remember it like this. Obturate means to close or to finish kind of thing. So obturator means when you are trying to rotate the thigh internally. That is, you're trying to close the thigh. You have right lower quadrant pain. That is called obturator sign. Right lower quadrant pain with internal rotation of right thigh. What is Rovsing sign? When you palpate the left lower quadrant and you have pain in the right lower quadrant, it is called Rovsing sign. You have rectal tenderness. What is rectal tenderness? When you are doing rectal examination, patient has right pelvic pain, especially when there is pressure on the right rectal wall. It is called rectal tenderness. You are applying pressure on the rectal wall, but you have pain in the pelvic region, that is right lower quadrant. This is the significance for pelvic appendix or abscess. These are the examination signs of appendicitis you can find. Now let's go to the management. You have suspected appendicitis in a patient, right? Alvarado score is more than 4. Now, what diagnostic test should we do? First, you need to check if the female is pregnant or if the patient is a child. If yes, then you need to go with low radiation imaging, that is ultrasound. If ultrasound is not diagnostic, then you can go with MRI also. You should not do CT in these patients. What if it's not a child or not a pregnant female? Then you can go with CT scan. Now, after the imaging, you see a normal appendix. Then what do? Evaluate for other diagnoses. What if the imaging is non-diagnostic? That is, you cannot see any appendix. Then the management depends on the Alvarado score. What if it is a non-perforated appendix? Then you need to start with antibiotics and perform an appendectomy in less than 12 hours. What if the appendix is perforated? Then first you need to do bowel rest. Second, antibiotics. Then check if it's a contained abscess or there is diffuse contamination. If the abscess is contained, you can just do percutaneous drainage. But if there is diffuse contamination, you need to perform an incision and drainage along with appendectomy. Right? This is the management of appendicitis. Perforated appendicitis evolving into intra-abdominal abscess. The infective organism here is gram-negative bacteria, Bacteroides fragilis, E. coli, Enterococcus, Streptococcus. All of these are usually present in the gut, so all of these can cause the intra-abdominal abscess when appendix is perforated. That's why we are saying perforated appendicitis means it might cause abscess. So first check if the abscess is contained. If it's contained, then do drainage, percutaneous drainage. But if there is diffuse contamination, incision and drainage and appendectomy. Some other points that you need to know is during pregnancy, postpartum, the appendix undergoes cephalad displacement by gravid uterus. Therefore, with increasing gestational age, patients may have atypical presentation of pain in the right mid to upper quadrant or right flank. Basically, what this sentence is trying to say is usually appendix is in the right lower quadrant, right? But due to the displacement from uterus, as the gestational age increases, the appendix keeps moving upwards. So it might go to right upper quadrant, and hence in pregnant females, it can mimic cholecystitis also. May mimic cholecystitis pain. What are the obstetric symptoms in this case? Uterine irritability and contraction because of the inflammation, and it might also cause fetal tachycardia. Now, what is the management of patient with appendiceal abscess? Same thing. Bowel rest, antibiotics, hydration. Appendectomy should not be performed right away. Patient can return in 6 to 8 weeks for elective appendectomy, but this is very controversial point. So, main thing is IV antibiotics, fluid, and bowel rest, and appendectomy should be performed, but it should be performed immediately or we should wait. That point is controversial over here. Another thing you need to know is with appendectomy, the risk of infection is very high, especially with laparoscopic appendectomy. Whereas when you do laparotomy, that is open surgery, the risk of infections is significantly reduced. Infections are the most common complication of appendectomy, and risk of intra-abdominal abscess, example, subphrenic abscess, is significantly higher with laparoscopic than laparotomy. Manifestations include recurrent fever, abdominal symptoms, that is pain, vomiting, several days after an abdominal operation, right? Because you have an abscess, fever is compulsory. You'll have pain. Other than that, vomitings can also be seen. So, subphrenic abscess will have all these symptoms several days after an operation. That is it for appendicitis. Now we'll see what is pseudoappendicitis. Pseudoappendicitis is infectious ileocecal. This is ileum and this is cecum. So if there is any infection in this part, ileocecal part, it will cause pseudoappendicitis. And when does that occur? In Campylobacter gastroenteritis, or it is also seen with Yersinia enterocolitica. Epidemiology is undercooked poultry. Clinical features obviously same like appendicitis. You'll have fever, abdominal pain, but here you'll have diarrhea, bloody diarrhea. Pseudoappendicitis, right lower quadrant pain can be seen due to acute ileocecal. Treatment is supportive care and antibiotics only if it is high risk cases or severe. So, what are the high risk cases? Even after 7 days, you have the pain, you have bloody stool, you have high fever if the patient is immunocompromised. These are the high risk cases where you need to give antibiotics. Only in the severe or high risk cases. Complications of Campylobacter includes GBS and reactive arthritis. And what is the antibiotic that you need to give? Amoxicillin, only if it is severe. Differential diagnosis is appendicitis and cecal diverticulitis. Appendicitis has mild diarrhea versus profuse mucoid or with bloody diarrhea in pseudoappendicitis. And also, you have a presence of sick contact in pseudoappendicitis. What about cecal diverticulitis? Mild diarrhea can occur in this. In addition, diverticulitis is exceedingly rare in children. That's it about the pseudoappendicitis. We have completed appendicitis and pseudoappendicitis. Now let's go towards the psoas abscess. What is psoas abscess? First, you need to know about the psoas muscles. You have psoas muscles coming here and attaching. One is attaching to the femur, one is attaching to the pelvic bone. That's why when you have an abscess in this region, abscess is rim enhancing hypodense fluid collection, right? And you can see that this abscess over here. Kidneys are displaced anterolaterally by the abscess. You can see an abscess over here. Abscess will obviously have fever, abdominal pain, or flank pain. And since you just saw the anatomy, it may radiate to the groin or hip. You can see anorexia, weight loss, abdominal pain with hip extension. That is when you try to straighten your legs, you see abdominal pain. That's why they try to fold their legs, flex their legs. Diagnosis CT scan should be done, and pain decreases on flexion. Leukocytosis will be there obviously because this is an abscess. Inflammatory markers will be increased. You need to do blood and abscess culture. Treatment is obviously abscess means drainage should be done and antibiotics should be given. That is it. What is the etiology of psoas abscess? Hematogenous spread, direct extension from adjacent or intra-abdominal infection. Like patient had vertebral osteomyelitis, diverticulitis, TB, spine, pyelonephritis. Adjacent infections are going and causing psoas abscess. Risk factors. What are the risk factors? Patient should be immunocompromised like HIV, drug use, diabetes, Crohn's, immunocompromised state. This might lead to psoas abscess. There was a question. 40-year male, worsening right lower abdominal pain, radiating to right groin. Pain since 7 days, slowly increasing. Patient has fever and anorexia. 2 weeks ago, treatment for furunculosis of right thigh. Known case of type 1 diabetes. So you can see there's an adjacent infection going on and patient is immunocompromised. Temperature is 101.9. On examination, tenderness on deep palpation in right lower quadrant is there. Extension of hip increases pain and flexion decreases pain. Bloods, bowel sounds are present. Rectal examination is normal and skin is normal. Labs may you can see anemia. Leukocytosis is seen, platelets are slightly increased. As you can see, thrombocytosis is there. So that points towards psoas abscess. That is it for psoas abscess. We are done with psoas abscess. It's very easy. Now coming to small intestine obstruction, the last part of our small intestine pathology series. The obstruction of small intestine depends on anatomical location. There's complete proximal obstruction or mid or distal obstruction. When you have proximal obstruction, that is, there's obstruction at the start of the intestine. Now let's analyze it based on this part. So proximal obstruction in the start only. In the start of small intestine only, you have an obstruction. This will lead to early symptoms, right? The earlier the obstruction, the earlier the symptoms you get. But if you have an obstruction in the later part, that is distal part, then you will have delayed symptoms. See, complete obstruction, complete proximal obstruction, early vomiting will be there, abnormal contrast filling on X-ray. Whereas distal obstruction, delayed vomiting is there, you have pain, distension, constipation, obstipation, hyperactive bowel sound, X-ray will show dilated loops of bowel. Now coming to simple versus strangulated obstruction. Simple means only lumen is obstructed, whereas strangulation you have loss of blood supply. This will cause what? Ischemia. Ischemia will lead to peritoneal signs, that is rigidity and rebound tenderness, and you can also see shock signs, that is fever, tachycardia, and leukocytosis. Now coming to etiology. You just need to remember A, B, and C. A is adhesions. Adhesions can occur due to prior abdominal surgeries. B means bulges, hernia. C is cancer. So ABC of small bowel obstruction. Presentation, you'll have pain, vomiting, unable to pass flatus or stool if complete obstruction. You have hyperactive bowel sound. Later it goes to completely absent bowel sound. Distended and tympanic abdomen. What about the diagnosis? On X-ray, you can see dilated loops of bowel with air fluid levels. This is small bowel or dilation, right? The bowels are dilated fully. Here you can see air fluid levels here. This is the fluid level and this is the air. Partial, you see air in colon, whereas complete, you have abrupt cutoff, no air in colon. See, you are having all this air in your colon and then suddenly there's no air. Distal large bowel is decompressed. Complications may include ischemia, necrosis, that is strangulation or perforation. Management, you need to do bowel rest, NG tube suction, IV fluid, serial abdominal examination. First, you need to do this, but if the patient has hemodynamic instability, go for surgical exploration. If you have any hemodynamic instability or there are signs of complication, that is strangulation and bowel perforation. Just as I had mentioned, SBO obstruction with hemodynamic instability, that is fever, hypotension, and tachycardia, urgent surgical exploration has to be done. Most common cause of SBO is adhesions. A, B, C, you need to remember these. Typically from abdominal operations or inflammatory processes like Crohn's. Can be congenital like lad bands in children. Now we have a condition that resembles SBO, that is ileus. We have already discussed ileus versus SBO during the initial part of our video. SBO etiology was prior surgery, weeks to years, anywhere between weeks to years. If the patient has had prior surgery, then it might cause adhesions, which might be the cause of SBO. Whereas ileus, recent surgery, hours to days, metabolic, hypokalemia, hypophosphatemia, medication induced like opioids. Abdominal examination, you have distension in both cases. SBO may you have increased bowel sounds, whereas ileus may you have decreased bowel sounds. Small bowel dilation is present in both of them, whereas there is no large bowel dilation in SBO. In ileus, the large bowel is also dilated. There is no transition point. You have to remember this. What is the management of ileus? Conservative management, bowel rest, and serial examination should be done. What is prolonged post-operative ileus? When your ileus is not resolved even after 3 to 5 days post-op, it is called prolonged post-operative ileus. Even after 3 days, more than 72 hours surgery. What are the risk factors? Surgical complications like ureteral injuries is the most common cause. Bowel manipulation was done, longer surgery duration. Bowel sounds are decreased and you have absent flatus. What are the prevention techniques? Give the patient epidural anesthesia, try to do minimally invasive surgeries, judicious peri-op use of IV fluids to decrease the GI edema. Paralytic ileus is most commonly a complication of abdominal surgery, but it can also be seen in retroperitoneal or abdominal hemorrhage, intra-abdominal inflammation like pancreatitis, intestinal ischemia, and electrolyte abnormalities like hypokalemia, dehydration, and increased creatinine. That is it for small bowel obstruction. Before we end this module, there's two more conditions that we need to discuss. First is lactose intolerance, that it is due to congenital or development lactase deficiency. Small intestine infection or inflammation can also cause lactose intolerance. After dairy intake, if the patient has GI symptoms, then it is lactose intolerance. Diagnosis: dairy restricted diet resolves the symptoms, and lactose hydrogen breath test. Management is dietary restriction of lactose, lactase replacement if dairy is ingested. Next, coming to tropical sprue. It is similar to celiac sprue, but this one responds to antibiotics. Celiac sprue was due to gluten, so you need to go with gluten-free diet. Here it responds to antibiotic. The cause is unknown. It is mostly for the patients who have gone to the tropical area. The name itself spells out the disease, tropical. Recent visit to tropics or a resident of a tropical area. It also decreases the mucosal absorption of duodenum and jejunum. Over time, it involves ileum too. Folate and B12 deficiency can be seen. Now comes the last topic, and with this, we'll end our session. Whipple's disease. What is Whipple's disease? Infection with Trophorema whippeli. You just need to remember this one sentence. Pass the foamy whipped cream in a can. Whipped indicating Whipple's disease. Pass indicating pass positive. Foamy whipped means foamy macrophages. Can, C is for carditis, A is for arthritis, N is for neuro disease, right? And you'll always obviously see diarrhea or steatorrhea in the later course. Most common in old males. Treatment is antibiotics because obviously it is due to gram-positive bacteria. Treatment is antibiotics, ceftriaxone. You need to use long-term treatment. More than 12 months treatment is required for Whipple's disease. And with this, we complete our small intestine pathologies.